the UK Psych Health and Safety and ISO 45003 podcast.
Welcome to the latest episode of the UK Psych Health and Safety podcast. My name's Sheila Lord. I'm joined today by Peter Kelly, my co-host from the HSE. And also our guest this week is Emily Pearson, who is the Managing Director and the founder or co-founder of Our Minds Work. I met Emily through LinkedIn, saw a lot of what she was posting on LinkedIn. We had a lot in common, reached out, connected, and yeah, we are connected now.
Fully connected.
So Emily, do you want to introduce yourself and tell us a little bit about you, your background, and kind of how you got involved in this field of workplace mental health, really?
This very new field, yes. Pretty kind of exciting journey, actually. So my journey probably started when I was about 12, 13. I'll make it a short story.
Right, I'm just going to get a coffee and I'm sick.
I've got this in 3 minutes down to repeat, don't worry about it.
This is an audio podcast. For those of you that are listening on the radio as an audio podcast, Emily's house is absolutely lovely, and it always looks 100% whenever you do anything with her. So I'm just giving them a visual image.
A visual. Oh, well, thank you. That's very lovely. I need all these plants for all the oxygen that I use up talking about mental health and mental health first aid. So that's why all the plants are there in the background. So, no, from a very, very early age, I struggled with my mental health. Really after my parents' marriage broke down, at the age of 12, 13, you're very influential in your peers and what's going on in your life. You don't particularly have great coping strategies. So yeah, I kind of struggled with my mental health all throughout my teens. Had my daughter at the age of 18, so very, very, very young parent. Left home when I was 16, so away, independent, just trying to work my way through my life's challenges at such a young age. And I'd always had an interest in mental health and myself and self-improvement. And my first ever job, actually working in any type of mental health role, was with the elderly mentally ill. I was only about 19, 20 years old then. That was my first job ever, working with the elderly in a secure environment who had, mental health diagnosis conditions. And I loved it. But what I didn't have at that point was any type of training or qualifications. So I was about 21 when I really got into looking to make it into a career. And I went back to college, studied counselling, started to study psychology, and then I just thought that wasn't really floating my boat. I really wanted to connect with people in a little bit of a different way. And you've probably heard us talk a lot how I'm not a huge fan of labels and diagnoses, so it just wasn't really for me. But what I found really was for me was the world of health and social care, and more around intervention work and actually being able to just really connect with people and help them to get through challenges. Like I felt as if I didn't have anyone who supported us through that throughout my, my teens and very early 20s. So around about the age of 21, once I'd started this work, I was actually working at Children and Young People's Secure training centre. So this was for young people who were too young to go into a young person's institute. So I was a custody and interventions worker in there. And about a year and a half into that work, I had a breakdown and experienced severe mental illness, which was probably coming for a long, long time, to be fair. I was diagnosed with depression, clinical depression, anxiety disorder, panic disorder, and anorexia. It was like a game of bingo being sat in that doctor's chair, It was like, oh, well, this is wonderful. All these labels to deal with. And actually, on reflection now, working in health and social care for over 20 years, what I really reflect back on was that I was just experiencing severe symptoms of human mental distress and suffering. I do not connect myself with having those labels, you know, that I feel as if I was responding in a very normal way to all of the things that I'd gone through very, very early in life. So that obviously was a huge part of wanting to do more in the health and social care space. So I've then spent the past 20 odd years working with children and young people, mental health, drug and alcohol, looked after care, criminal justice, and the same in adult services as well. So adult services, homelessness, dual diagnosis, mental health, substance misuse. And then luckily 6 years ago, I had the opportunity to work with National Mind, probably on the first ever mental health workplace program ever, because obviously 6 years ago, nobody was talking about mental health in the workplace. So it was very, very new. The program was the Blue Light program, so it was government funded, and I was part of an amazing team that created a workplace mental health initiative for emergency services. Up in the Northeast, we had one of 6 pilots, and we had one of the most successful pilots out of it all. And I just thought, wow, this is amazing. The impact that we were actually having on these services was phenomenal. So I just thought, well, if we can do this in emergency services, we can do that anywhere. And that's what led to the creation of Our Minds Work and our workplace mental health culture change program, models, initiatives, qualifications, and everything that we do to create mentally healthy workplaces. Yeah.
And I think that's one of the problems, isn't it? It's not the training's not the issue. You know, it's great that organisations are training. It's great that they're doing the mental health awareness, mental health first aid, whatever that mental health champion, advocate, whatever we want to call them. They're doing the training, they're talking about it, they're bringing it into the organisation, they're bringing it into the culture. So all of that, great news. But as you say, what is the thought process behind it, though? You know, what is the safeguarding? Is it brought into policy? You know, we see, I've seen a lot of people that have come onto the first mental health training that have then gone, but I don't know what to do next. And I think sometimes, and this is some of the work that you do, isn't it, Emily, that there's not enough thought put into this.
Absolutely. And I come from a background of health and social care. I understand everything when it comes to infrastructure, policies, procedures, keeping people safe, because safeguarding people is a priority in health and social care, and not creating further harm for people is a value that we all work to. And had set up previously a counselling service. So we can use this as an example, you know, to have a counselling service. You have compliance that you have to set up. You have to have very, very clear triages, policies, procedures. This is what we do if somebody is in crisis. This is how we manage these responses. Okay, mental health first aiders are not therapists, but they still need that level of safeguarding and infrastructure around them, because the situation is the same. If somebody is in crisis, whether they're in a therapy room or sat with a mental health first aider at work, the situation is exactly the same, and there is a duty of care to protect people. So one of the first things, if we're looking at it in regards to a counselling and a service in the workplace, one of the first things that I think mental health first aid tends to be missing, which is a huge part of safeguarding people, is that there is no safe recruitment process. It's just, who would like to be a mental health first aid? Put your hand up, brilliant, come on this 2-day training, there you go, cheerio, see you later. We'll maybe have a meeting once every couple of months just to see how things are going. It's just not good enough. That's not only putting the mental health first aiders at risk, it's actually putting everybody in that organisation and potentially the business at risk as well. So, you know, there are lots of kind of pitfalls along the way that creating these additional risks by actually implementing it and not implementing it safely in itself. So one of the things that we recommend to organisations is that they actually put people through a DBS check if they want to be a mental health first aider. They go through that process to ensure that they're keeping people safe And this is about safeguarding potentially vulnerable people. Yeah, when we talk about people in the workplace who are adults, who may be vulnerable because of their mental health problems. They may be vulnerable because of having a diagnosis that's classed as neurodiverse, like autism. These can then be classed as vulnerable adults. We need to protect these people. So when we're putting people in such a responsible role, we've got to think about that level of protection. And even young people, a lot of workplaces have young people who work in those workplaces. If a young person comes to speak to a mental health first aider about their mental health, that young person is actually automatically classed as vulnerable because of their age. So there is this massive lack of safeguarding people as a priority, even before that recruitment process has even started. A little bit further down the line, obviously the training, I know for you, the training, I probably have a little bit of a different thought on mental health first aid content, because I'm not a fan of diagnoses and labels. We look at levels of human suffering and what support people need, rather than labeling it as something that I feel the DSM is made up of pseudoscience. I don't think it's based on scientific evidence that schizophrenia is a mental illness that is only to do with the brain. So I just feel like we're giving information out that probably in 10 years' time is not going to be factual at all. And we're actually starting to see a lot of that come through. I mean, if we were sat here in the 80s delivering mental health first aid, one of the sections you would have had on mental health first aid training is about people being gay and lesbian as a mental health disorder. So, it's like, so that's my feelings on the training content itself as well.
And contextualizing, and I'll come in later, is 2% of the population will suffer severe and enduring mental health problem, of which that represents 80% of where the funding currently goes for the 2%. So it's those who have schizophrenia or who have prolonged personality disorder, etc. So in the context of work, we will have people that are schizophrenic in work, but they will be under specialist services, most of them, and most of them should be supported. And if not, they will get those support because they have a severe and enduring mental health issue. Whereas actually 20% of the population pre-pandemic were thought to be experiencing depression and anxiety. And what we're seeing is an increase in reactive anxiety and depression during this pandemic, and obviously the coming years. So we will see an increase, and I suspect it will go to 1 in 3, 1 in 4, maybe, depending on what the numbers look like. But let me sort of jump in a little bit. Had you asked me 10 years ago, would we have 1.2 million people trained in mental health, I would have said yes, because I would rather have which is what we're looking at, because it's a global thing. Mental health first aiders. I know in the UK it's around 290,000 people have been trained in mental health first aid, and there are people that had a degree of training, 2 days training, in which they've covered mental health, and so they have some information. I think that's a good thing, because I'm a mental health advocate, as you, Emily, and I want people to get out and realize actually it's okay to talk about your mental health. It's okay to feel, I'm struggling, I'm having a bad day, and what does that mean, and etc. It is right, as you'll talk to. It was developed for communities, and it was a community-based intervention in Australia, and it works as a community-based intervention. It can also work to raise awareness, which is the first level of cultural change of what we need to do. So the issue I have had is, and I publicly said this, is actually when you don't do that, when you just do that, you raise awareness, but you don't put infrastructure in it. We get into a situation, as you've said, where safeguarding and issues regarding what do you do when you've got a suicidal case at 8 o'clock at night, and who do you phone, and how do you then care for the carer, the person who's actually taking the call, and I know that mental health first aid are doing some research, and they've asked myself and a couple of others to be independent reviewers of what that research shows with regards to evaluation and going forward. And what I'm saying now, I would publicly say on any platform, which is the challenge is, what do you put in afterwards? If you're going to train people, train them, but give them something else, which is where we're always at, Emily. We have this conversation before over LinkedIn and at conferences when we do meet, when you tap me on the shoulder and oi, and then we sit and we talk about it. So it's here. It's my challenge and your challenge and the challenge of anyone in this community to say, put the organizational bit in. Actually, what are you doing to manage and support people once they've got it? Once you raise respect to hear someone to talk to you about depression and anxiety, but you've done nothing about it. We know suicide, again, is a very rare event in the context. And, although suicide numbers are rising since we've seen in the pandemic disproportionately from previous years. But so the bulk of what these people will see are people with depression and anxiety. And actually, there are things the organization can do and don't do to manage people's mental health, their depression and anxiety. There are things that you can do systematically for someone who's got a severe enduring mental health problem. But you get the services to do that. You buy into the government support networks and the NHS and social services to do that. But you don't have that for the 1 in 5 or the 1 in 4. Yeah. Wow, that was just a quick 2-minute. I went off on one, didn't I? Sorry.
No, but I think, there's something I just want to pick up on what you said there, actually, about the safeguarding element of it. So yes, risk of suicide is just a small part of safeguarding. If you are opening the doors to come and talk to me about your human suffering, they can be triggered by all sorts of stuff. You can have people sat there talking about domestic violence, domestic abuse. You could have people sat there talking about neglect, child abuse, even putting people at risk themselves, so that it's not them that's at risk, that it's them that may potentially be putting somebody else at risk of significant harm. Mental health problems that might be putting their children at risk at home. These are really, really difficult situations to manage for somebody who's been on a 2-day mental health first aid. In fact, it would be impossible for them to do that, even down to somebody being sat in front of you saying, I'm struggling with stress and low mood, so I'm drinking till 3 o'clock in the morning to get to sleep. And now that person's at work driving a truck around the site. It's so much broader. Much broader as well, isn't it? I talk about safeguarding as like this massive piece of safeguarding everybody.
We've both come from backgrounds in social care. I was a specialist challenging behaviour nurse in the days when they could call us challenging behaviour in learning disabilities and mental health. So you've seen all the spectrum of what happens. The only problem that I got really annoyed and frustrated was I was seeing people that were ill. And I was thinking, as a psychologist, when I was doing clinical work, it was like, well, I'd say in a clinic in a day where I'd see 4 people over an afternoon, 2 to 3 of those would have issues at work that were a collaborating factor in why they were displaying depression and anxiety. And that led me into going into work in HSC on a different area, to be honest. It's only when the new government came in and they said, oh my God, 6.5 million days is too much. I'd give my right arm for 6.5 million days now to work-related stress and mental health. But yeah, that drove me because I wanted to do something to look at the source rather than the back end. The back end's a terrible expression, but you know what I mean? When you've got depression and anxiety, it's a different treatment course. It's a different direction. What if we were doing preventative stuff? What if we were actually managing workplaces? What if we were effectively looking at the systems and processes? I'm so tired of people telling me I've got a great system which makes people ill. That ain't a great system, is it? That's a disastrous system, because you don't have a system if you don't have your people. Sorry, I'm picking up my phone. That you go into organizations all the time, Emily, and you're like, actually, you want me to do that, but you need to sort that out.
Absolutely. And I think this is where having now this global framework, I think with the ISO standard, is going to really, really help organizations to understand and really think about how they actually pull this together, so it becomes part of this continuous improvement, an element of the business that just needs to be evaluated and assessed and reviewed on an ongoing basis, because we just can't dip in and dip out of mental health with a training course here and a training course there. And as you said, Pete, it really does have to be that systematic and that systemic piece, doesn't it? So,
yeah. I mean, as a regulator, and if you tell me you've got mental health first aiders, you've done resilience training, you've done mindfulness training, I go, okay, but what did you do to manage the risk? Because that's not the risk. What you're doing there is managing the outcome of that risk. Because really, you should be putting systems in place that promote health at work. I didn't know about you. I didn't sign a contract when I joined to be made ill, like mentally ill when I went to work. Where's that in that employment contract that we signed? You know what I mean? And it's just, I'm always, I'll go on about this until probably I'm retired, and I'll probably still go on after that. But it's about managing the health of people, and not just treating people as individuals, but treating them actually as realizing that there are consequences to systems and processes that are dysfunctional, and they don't collapse. It's the people that take the hit. Maybe they do collapse. That's when we have accidents, don't we? When I actually have to go in and say, well, where did it fall apart? Where does it fall apart? Did it fall apart with the system? And there's, oh, no, he didn't do it. But why didn't he do that? Why didn't she do a particular action? You facilitate it by not looking at the system. If you by looking at your people and just putting your people and saying it's something down to the person.
Yeah, well, I think that's just a lack of, again, a lot of workplaces with the rise of workplace mental health. We've been talking about, I know I have been talking about culture change since we first ever started about talking about workplace mental health. But one of the biggest problems is there's nobody in a workplace who understands how to create culture change. I think probably the people who know the most are generally health and safety, because they're trying to change the culture around creating a health and safety workplace. So you probably know of the social ecological model, Peter, coming from health and social care background. We know that you have these layers within the social, can't even say it. I've got your wobbly gob, Sheila.
Wobbly gob.
That's what we call it, the wobbly gob.
Phrases.
Here's what happened when you have two northern lasses on a pod.
The social ecological model, it's layers, and you obviously have the individual at the center of that. And then as your layers go out, you've then got what support's available for those people with regards to, their family and friends and their community support. Then as we go out, we've then got organizational layer as well. So within the organization, how are we changing the processes, procedures, the managers, the way the leaders are leading, all of this organizational change will impact. And then you've got your policy changes as well, policy changes out in the normal world versus policy in your environment at work. All of these different layers have to be intervened in and changed if we truly want to get a mentally healthy workplace. So one of the things about the new ISO standard that you've already mentioned, Sheila, I've had a little look at what people are saying about it. I haven't actually had a look at the actual standard, because I think I had to pay something like £118 to download a PDF.
No. You can get it for free now.
Oh, can you? Brilliant.
Yeah.
I'll find the free version and have a more in-depth look at it.
I'll send you a link.
Brilliant. That'll be wonderful. I think from my perspective, just from what I've seen, standards are always a great way of saying, these are the minimum standards that you can achieve to help to create a psychologically safe workplace. And I'm guessing it'll provide some level of tools in there to actually do it. One of the biggest gaps that we've seen in the workplace with any kind of like culture change that we're trying to create is, if you think about culture, you will have usually a statement from the SMT team to say, this is the culture that we want to try and create this is the culture we want in our workplace. And then you will find that those leaders may not actually have the capabilities to actually implement that culture themselves. And then underneath them, you've got, 50, 100, 1,000 managers who are all creating their own cultures in their teams or departments, and usually by default. Yeah, so managers will come into work and they will lead and manage with whatever capabilities they have. So that then leads us to culture that isn't actually a common goal for people. So not everybody has all the capabilities to achieve that overall culture as a common goal. What we want to create is the common goal to be a mentally healthy workplace. Yes, because the outcomes of that is operational excellence. The outcomes of that is higher performing teams without the burnout. The outcomes of that is that workplaces have purpose, they build the reputation, the psychologically safe places to work. They have less stigma, lower litigation, teams feel much more happier just being at work with a leader who is focused on having a mentally healthy team. Yeah, all the other good stuff, all the benefits that we want to have a thriving workplace comes off the back of that, in my professional opinion.
Which is effectively what the standard is trying to achieve. So you formalize the structure by putting it under 45,001, saying here's the safety management system. Mm-hmm. And then they go, oh dear, but where does psychological health fit in? Well, psychological health fits in at the heart of safety management, because your people's mind state and presence at work is a determining factor in safety outcomes, but also it's actually hugely important if you're looking at the longer term health issues which are there. So that's what the standard does. It tries to set out to give you a structure and system to identify those, and in a language that hopefully is simplified. It took a long time, like 3 years, to simplify this language, and even then, I always was on about, who's the audience? Who are the people we're trying to go? What does this actually mean? We need to make it really easy to understand. It does have tools in there. Yes, it does. It talks about the Canadian standards. It talks about the management standards. It talks about the Australian standards. It talks about total worker health. You can use whatever standards that you have in your country. And what the process is supposed to do is complement that. So if I go in as an inspector and I ask you, what have you done on managing work-related stress and mental health? If you put some of the principles of 45,000 in mind, you're going to be in a safer place, because I'll be going, okay, so you've assessed the risk and you identify the risk by doing this, and this is, so for me, it's showing an awareness that you're savvy to the area. Now, you equally could go into places, as we have done, they go, what risk assessment for stress? You're like, yeah, the risk assessment for stress. But what we're now going to have to address is actually, mental health is going to be one of those key occupational health issues probably for the next generation. We know there are the fallback that related to pandemics. We know we had a problem before at 17.8 million days lost to stress, and at 828,000 people off. That's a problem. That's the most. Right, that was before the pandemic. Okay, they might go down because people could be presenteeism, but I can guarantee they'll be going up, because actually what we're seeing, and we see this in the healthcare workers, is 20% increases in depression and anxiety. 20%, 44% of all sickness absence in the NHS at the moment is related to depression and anxiety and common mental health problems. I'm doing a webinar in 20 minutes on a global summit on physician burnout. We're losing hundreds and hundreds and even thousands of people from the care services that me and you worked in, and understand it was difficult then. Well, fundamentally, the COVID-19 has really, shown up their weaknesses in that system.
Yeah, without a doubt. And I think burnout in health and social care is much more complex than just the standard of what we think of burnout. Working in those services and understanding it from a personal experience, they experience compassion fatigue on top of burnout, and that is what ends people's careers in the job that they
go in because it's a vocational career. You want to make
go into it so passionate to make a difference, and you
come out of it, or you think clinically, what else can I do? Okay, I'm going to step out of that, and I'm going to target the sources rather than waiting for offering a solution to the problem.
Yeah, definitely. But no, I totally get the standard, and I will look at it in a little bit more depth. I think for me, one of the gaps, I think, is, and this is one of the gaps that we've seen for a very long time, is even in health and social care, you had your standards that you had to work to, but you also need people to have the capabilities to be able to implement those standards. Now, if you have just got HR and health and safety implementing an ISO standard, what about all the other managers who actually need to have the capabilities to also create a mentally healthy workplace? Every day they come to work, that's their focus, and they have the skills, they have the knowledge, they have the tools to be able to actually implement that on a cultural, team, department, wider organizational level, because a standard's brilliant, but you need people with the capabilities to implement it and actually embed it into the culture and fabric of the organization as well. So that for me is one of the gaps, and that was one of the reasons why we created our level 4 workplace mental health leadership diploma, because we've got 2 days mental health first aid. You can do a 1-day manager's course for mental health, but what you can't actually get until we created this program is actually a 14-month transformational leadership culture change program that builds the capabilities of managers into transformational leaders with the common goal of creating a mentally healthy workplace. And it takes a long time to do that. That's why it's a 14-month program. So I think that's some of the gaps that's been missing, is actually, you're right, we've done the awareness piece, we've done a lot around anti-stigma, but we haven't actually done the capabilities piece.
Yeah, and I think as well, just kind of, we're going to kind of come into the end of our 40 minutes to summarize, the standard is there. And, I think the one thing that's really, really clear with workplace mental health is there's no one single solution. Very organization specific. It's very specific to the culture, as you say, the capabilities of the people within the organization. There's never going to be one solution fits all. It's about taking the right pieces of the puzzle and putting them together relevant to your organization,
layering them up. Yeah,
absolutely. And in consultation with the people that work for you. I think that's one of the big pieces that's often missing, is just speaking to people. So just, Emily, just to kind of close off from today, that one thought piece for business leaders, that one key piece of advice that you would be giving out there, what would that be?
Train your managers. Every manager and leader who is responsible for other people in that workplace should all have the knowledge, skills, tools and capabilities to go in every day with the common goal of creating a mentally healthy workplace. It's as simple as that for me. Yes, you can layer initiatives up after that, like your mental health first aid, like your awareness for employees, your EAPs, all of that other stuff. But you've got to start with prevention and supporting and reaction. And it's the managers who have the responsibility to do that. So let's give them the capabilities to be able to do it as well.
Fantastic. Peter, anything you want to add before we sign off today?
Just let them go home healthy.
Yeah.
They came in healthy, let them go home healthy. And it's, Emily's a kindred spirit with me on this. And probably drawn from both of our own personal experiences of watching, mental health services going wrong. And obviously, from the, from our understanding of just workplaces. And I'm going to leave you with one thing that my dad said to me, and I said this at his funeral yesterday, I'll say it today. Why don't they just care for each other? Dad once asked me, he said, what do you do, son? I said, I work with organizations to help them manage people's health and their mental health. And he went, isn't it sad? Why don't they just care for each other? And I went, got it, Dad. Mm-hmm. And why don't we just care for each other? Why do we not show care? Why do we cut that off at the legs and go, we're not going to show care and compassion and empathy? And you're going to get so bored of me, but that will be my story, which is empathy and compassion in workplace. Let's start caring for people. Let's start caring for their mental health, because we put a guarding in front of a machine, and that's what we're doing here. We're putting a guarding to protect their mental health. I just want people to be in work, to go home and to have a life, not even if it's not fulfilled, at least they're going home and being able to connect with their family,